So hello everybody, and thank you very much for joining me this afternoon. Uh, I just want to mention that for the coming week, we're going to have a lot of interesting and live talks. I specifically want to mention for tomorrow Richard Harvey, and for towards the end of the week, you're going to have Professor Oliver from Columbus, Ohio, in the United States, and he's one of the leaders in the field of cochlear implants. And you gotta hear what he has to say. So basically, I want to talk today about what I call CC insight into the Eustachian tube. I think the Eustachian tube is the topic of a lot of discussion nowadays with the different techniques that we have to address pathology within the Eustachian tube. I think what's motivating really all this effort is the fact that for now, when all of a sudden we have access into the Eustachian tube, so we could see things, we could investigate things, and hopefully we could fix things. So I'm going to start my slide presentation. Second, sorry. All right. So you probably notice that I had included Heinz' name on this talk. Many of you just think of Heinz as a rhinologist, but I have to tell you that Heinz first was a big-time head and neck surgeon. And he also dabbled in otology a lot. Actually, the first time that I met Heinz was, I would say, 1980. And I know that makes me a bit old. But Heinz at that time, of course, I was doing my residency training in Montreal, and Heinz came to Montreal to talk about endoscopic sinus surgery. And at that time, as a resident, I had presented a case of actinomycosis in the temporal bone. And he took a special interest in that presentation, and really my relationship started with him from that period on. And when I started doing my endoscopic ear surgery stuff, he really knows the ear inside and out. And many of the work that I'll be discussing now is something that Heinz. It was really mostly my investigation and my research and my doing, but really exchanged a lot of thoughts on this with Heinz Tamberger, and he really views the Eustachian tube as part of the sort of the upper airway. And a lot of the disease process that we have in that area is really part of the general disease process that we see in the nasal sinuses. So I have nothing to declare. I really have no financial or no commercial interest in any of the discussions that you will hear. So again, I keep showing the slides, and the idea is that, I need you guys to go beyond the concept of seeing more with the endoscope. I think the most important advantage of using the endoscope is really to align the access that we have with the disease process that we have. And again, the problem is that when you cannot access through the ear canal, you have to access through the mastoid. And it really is a very different picture when using the endoscope versus the microscope. But I think, and this is the point that I want to discuss today, is that the endoscope really gives you access into the ear side of the Eustachian tube. And I think this kind of an access is going to prove to be very, very helpful to us in trying to address a chronic ear disease. Because I really think that this is the important end of the Eustachian tube. It's the end that has been long ignored, and it has been long feared, because for most of us during training, we kept on hearing the words of our seniors and teachers telling us, don't fool around in this area, don't look in there, it's not a place that you want to be. And I think we've been indoctrinated to think like that. But I think we have a great opportunities with the endoscope of visualizing this area and rediscovering the anatomy. And this is what I'm going to be discussing today of that area. So when I say you match the ventilation or the physiology with the axis in that, and this is a 3D reconstruction that I have done on the workstation in our CT scanner. And basically, this is a left ear. You could see the ear canal, you could see the air cell system of the temporal bone. And this is like the outlining of the tympanic membrane, middle ear cleft, and you can see the Eustachian tube in here. So basically, if you ask any student of physiology and tell them like, where is the important areas in terms of ventilation, he would tell you that it's the most upstream areas right here. And the least important would be here, the most downstream areas for the ventilation. The problem that we have with our microscopic axis is that it runs in the other direction, in that we have a lot of terrific access with the microscope to the mastoid, but we have really no access into the most upstream area, which is the Eustachian tube. And I think that in general, for surgeons, access drives understanding. So when you have an access into one area, it gains importance in your mind. You want to fool around with it, and you want to attribute to it certain functions. And I think that's what happened with the mastoid cavity. But the real issue that we face with chronic ear disease is really more anterior into the Eustachian tube. So that's when I say aligning axis with the disease process. So basically, again, this is the same picture, and I just want to talk about the anatomy of the Eustachian tube. This picture that you have seen was done using the salva technique. The newer CT scans do have the ability to run through the temporal bone really quickly. So you have the patient could really hold his breath and do a Valsalva technique. And that dilates the Eustachian tube in a significant number of our patients. So you could visualize the whole length of the Eustachian tube. This was published some time ago in the laryngoscope. And you could see here, if you have to align your cuts in a certain way to visualize the Eustachian tube. So this is, you could see the whole length of the Eustachian tube in here. This is the nasopharynx, of course, and this is the ear side. But you gotta understand that to see this kind of a picture, you have, the plane has to be really tilted forward. This is not an axial cut. You could see the cut is going through here. This is a sagittal cut, and you could see the cut of the that you're seeing here in the red here. So you have to go in the direction of the Eustachian tube to visualize the whole length of the Eustachian tube. And again, this is using a Valsalva technique. And if you do have a 64 slicer CT scan, you should be able to see this kind of picture in about 1/4 of your normal population patients. And the nice thing about Valsalva technique is that it consistently visualizes the distal nasopharyngeal end of the Eustachian tube. So even in patients where you don't see the whole visualization of the whole Eustachian tube, you'll definitely, in a substantial number of patients, you'll be able to visualize the distal Eustachian tube. So I want to discuss what I believe is a very, very common misconceptions, even among, I would say, leaders of our specialty, about the Eustachian tube and the anatomy of the Eustachian tube. The first misconception that I would like to talk about, which is absolutely and unbelievably wrong, is the idea of the Eustachian tube as a simple tubular structure. And the reality of the situation is that the Eustachian tube is really more like a sac, and it's almost like even a pocket. And it's a very irregular in shape, and it depends on which side you're looking at it. It has a lot of very distinctive anatomy that we need to understand, because as we start doing our interventions in those areas, we really need to understand the anatomy of the Eustachian tube. And I found that the CT scan and the 3D reconstruction of the Eustachian tube with Valsalva is very, very, very helpful. So this is a right Eustachian tube, and we're viewing the right Eustachian tube from above. So this is the nasopharyngeal end of the Eustachian tube, and this is the ear end of the Eustachian tube. So all of these features that I'm going to be mentioning are features that are really, really consistent with the Eustachian tube. You could see it's a very irregularly shaped structure. The nasopharyngeal end of it is huge. It's absolutely huge. It's almost like a pocket. And the other end is very narrow and really happens to be at the end of that pocket. So it's almost like you're putting your hand in your pocket and there's a little hole at the end of the pocket. So it's really a mucosal fold more so than a tube. So I'm just going to orient it differently so you would be able to understand what's going on. So this is like looking from above down on the Eustachian tube. And this is the right Eustachian tube. So this is the ear side, and this is the nose side of the Eustachian tube. And you're looking from above to below. The first thing, again, just want to make the comment that the distal Eustachian tube is very huge, and it really is not the shape of it is you get this bulging laterally of the Eustachian tube, and you get this concavity medially. So this is a very consistent observation about the Eustachian tube. And the top of the Eustachian tube has this narrow top. And this is really the area where you have this cartilage, that's the incomplete cartilage that forms the top of the Eustachian tube. So inferiorly, it's more like a pocket. Superiorly, it's a very sort of a sharp ending, which is made by the cartilage of the Eustachian tube. So this is the Eustachian tube on the right side, the same picture, and it's viewed from the right. So you're looking as if you're looking at from the ear side on the right side and looking at the Eustachian tube. So again, you see the same thing. You see this bulging here. On the other side, you see this concavity. And the top of the Eustachian tube, the upper part of the Eustachian tube is very, very, has a very sharp contour. So you can see here, this is a very sharp contour, and here is almost like a bulge. And the bulge is not to the lateral, and from the other side, it forms like a concavity. All of these features are very, very important, because when we start instrumenting the Eustachian tube, and you're thinking that like it's almost like passing a catheter through a vein, it's a very, very different environment here. And if you don't understand the anatomy, you could end up doing a tremendous amount of damage to the field. And this is again the right Eustachian tube, and this is the just to demonstrate what I call the inferior pocket. There's always this inferior. This is superiority is here, inferiority here. This is the ear end, and this is the nasopharynx. And there's always this inferior pocket to the Eustachian tube. And really, if you're trying to introduce catheters through the nasopharyngeal end of the Eustachian tube, you might end up basically hitting this wall. So this is what I'm trying to demonstrate with this picture, is that you're trying to get into the Eustachian tube to do a dilatation, and you have this inferior pocket here. So if you insert it into the nasopharyngeal, insert the introducer or the catheter into the nasopharyngeal end of the Eustachian tube, and if you put it towards the lower end, you will basically end up creating a false passage here. What you want to do is basically lift it up towards the upper end, toward this sharp end that's made by cartilage, and go along the roof of the Eustachian tube, because here you will have basically a false passage if you do the introduction. Because the problem with the with the dilatation of the Eustachian tube as it stands right now is that it really is a blind procedure. You basically just insert pass the catheter through, and you're hoping that it ends up in the right place. So this is something that's courtesy of Dennis Poe, and basically he's just showing you this how it happens when you basically end up introducing the catheter inferiorly here. And let me show you the video.
I'll just show you how you can get a false passage. This is a cadaver on the right side. So this is a balloon being inserted with a 0-degree endoscope, and we don't see the anterolateral wall. So just pushing it in there, now I'm meeting resistance. So let's take a look and see if we're in place. There's that yellow marker, so it didn't go in as far as it's supposed to. That's a false passage. So here's a 45-degree view to see what happened, what went wrong. If you follow the anterolateral wall, that's the lumen. So the balloon went
that's a pocket
here
that I was
through a
talking
false
about
passage, and
superiorly,
this
and this
tissue
is
is very
Eustachian
thin.
superiorly. And you can see here how the formation of the upper end or the upper part of the Eustachian tube is very sharp upper end that basically formed by the defined by the cartilage. So that's again, the first misconception was the idea that the Eustachian tube is a tube. The second misconception is that the Eustachian tube is two parts, bone and cartilage. And the reality of the situation, the anatomic reality of the situation, is that the Eustachian tube is a cartilaginous structure. And it really connects the nasopharynx to the protympanum. And let me just explain to you, because I think, again, for years and years and years, we've been taught that about the bony Eustachian tube and the cartilaginous Eustachian tube. But I think it's really, as we gain access into those areas and as we start to describe our work to others, and as we start to try to communicate what we're doing in specific cases, we really need to have very, very different outlook on the anatomy of the Eustachian tube. So Eustachius, about 500 years ago, described the Eustachian tube as consisting of two parts, one bone and one cartilage. And if you really look at this is an axial cut through the temporal bone. And of course, you see the Eustachian tube down here, and this is of course the ear canal. And I have basically for localization, I've placed the ossicle. This is my own work. This is the carotid artery, and this is the cochlea. So basically, as we gain access into this area, we're getting to recognize, well, this is the mesotympanum, and this is the protympanum. So where does the concept of a bony cartilaginous tube comes from? I mean, what defines the end of the protympanum and the beginning of the bony Eustachian tube? What really makes sense is that this is all protympanum. There's nothing called bony Eustachian tube. Really, the Eustachian tube is a cartilaginous structure that hooks up the middle ear cavity or the temporal bone into the nasopharynx. And if you look, this is using a 30-degree endoscope into the area of the protympanum. And you can see here's the carotid, and you see here's the tensor tympani muscle. And by the way, the carotid and the tensor tympani muscle always go like this. The carotid goes like this, and the tensor tympani goes on top. So if you insert a further insertion, you see the opening of the cartilaginous Eustachian tube into the protympanum. And it really opens up in a cuff-like protrusion, very, very much similar to what you see in the nasopharynx. So again, this thing's starting to make sense. The Eustachian tube is really a cartilaginous structure that ties up the temporal bone into the nasopharynx. So this is an editorial that I had written with some other colleagues, and basically what we're arguing in this situation is that the Eustachian tube, as viewed endoscopically, does not have a bony portion. It is basically a fibrocartilaginous structure that stretches from the nasopharynx to the most anterior part of the tympanic cavity. And it's really two openings are strikingly similar to each other. So this has been signed up by Dennis Poe and some other colleagues who are really interested in this area of research. And I have this histologic section, and it really is amazing to me. You can see here the cartilaginous Eustachian tube here, and you can see here the temporal bone. It really is amazing to me that somebody would decide to call this as bony Eustachian tube. It really is just part of the temporal bone. It's really part of the pertympanum. So it's, I think it's a big mistake to think of the Eustachian tube as either a bony Eustachian tube or a cartilaginous Eustachian tube. The Eustachian tube is a cartilaginous structure that ties up the pertympanum into the nasopharynx. So we move on to the, what I think is the third misconception about the Eustachian tube. And this is a mistake that, and I'm sorry to say that, but we surgeons really are very simple-minded people. We learn from our mistakes. We try to, once we learn something from our mistakes in the past, we try to teach it to everybody around us, to caution our students, to you know, in order to be safe and in order not to have complications. But the most, I think, striking misconception about the Eustachian tube in my mind is that the idea that the medial wall of the Eustachian tube is the carotid canal. And in reality, especially the cartilaginous Eustachian tube has really nothing to do with the carotid canal. It's basically the carotid canal intersect with the pertympanum at one point, and it's a very limited intersection because the pertympanum and the carotid canal run in a very, very different direction. So, so this is the third misconception that I really think that we need to understand, because as we gain access into those areas, we cannot be driven by the fear. And I have to tell you that, like, when I started looking into this and I started, you know, doing some dilatation of the Eustachian tube in certain areas that had been viewed before as part of very close to the carotid, I was basically shaking because, again, like everybody else, it has been drilled into my mind that, you know, God, you know, the carotid is right there. You know, you're going to damage the carotid, you're going to blow up the carotid, you're going to create, you're going to displace a atherosclerotic plaque, and the patient is going to have a stroke. And I think much of that, again, is driven by experience, by our teachers, and much of it is driven by this simple axial CT picture. And in that, when you're looking at this CT pictures and you're thinking, wow, you know, this is the middle ear cavity, and the Eustachian tube is anterior to it, so this must be here in the Eustachian tube. And look, the carotid here is right there. And so don't tell me you're gonna fool around with the Eustachian tube, because the carotid is right next to it. But this is really a total sort of misrepresentation of the anatomy of the area. And to demonstrate that, we go back again to the issue of Valsalva CT. And this cut here was made, this is an axial cut, of course, regular axial cut. You see the carotid artery here, and you see the middle ear cavity here. But this picture that you see here is basically what I call parasagittal. It runs through the Eustachian tube. So this is the green line here. So this is the picture here is what you see here, this green plane that cuts through the Eustachian tube. So ear canal, middle ear cavity, pertympanum, and this is the air within the Eustachian tube. And you can see here in this plane, of course, there is no carotid. The carotid is supposed to be here, and it is in a more medial location. So this is, we moved now, we moved this plane medially to cut through the carotid. So you could see the carotid here, the orientation of the carotid canal. So the carotid makes a genu here, and it turns around. But you can see this is the pertympanum. So you get middle ear cavity, pertympanum that intersects with this part of the carotid, and it's really almost like a right angle intersection. It doesn't run along with it. It's a right angle to it. It's like this. So it's a very limited area of intersection. And beyond that, you could see the pertympanum appears here again, and then you get the Eustachian tube. And what I have done here is that I basically superimposed one image over another to show you the cartilaginous Eustachian tube here, extending into the pertympanum, and you get the carotid that runs in this direction, and then you get the pertympanum here. So again, the Eustachian tube, which to me is the cartilaginous Eustachian tube, has really nothing to do with the carotid. The Eustachian tube, cartilaginous, is very distant to it, and even what they used to call the bony Eustachian tube, or the pertympanum, in my mind, only intersects with the carotid in a very limited sense. So I think this is a very important anatomic concept that you need to understand as you try to address pathology in this area. The fourth misconception about the Eustachian tube, I believe, is the idea that there is a junctional area of the Eustachian tube, both bone and cartilage. And the reality of the situation is that the cartilaginous Eustachian tube runs into the bony temporal bone almost in a male-female connection arrangement between the cartilaginous Eustachian tube and the temporal bone. So that area of this male-female connection is where you get what people think as a junctional area, but it really is not a junctional area. It's almost like I have this picture of a male-female connection. So if you plug this into this, you recognize this is a cartilaginous Eustachian tube, and this is the bony temporal bone, or the pertympanum. So in certain areas here, the cartilaginous Eustachian tube again dips into the bony pertympanum, and you can see it here also as well. You can see here this is the bone part of the temporal bone, and this is the cartilaginous Eustachian tube. So you can see it's basically it's not a mixed area. Basically, it's just the cartilaginous Eustachian tube going into the temporal bone, and again a male-female connection kind of relationship. The next misconception I think about the Eustachian tube that really also bothers me is that when people talk about Eustachian tube, they try to project the image that it's unbelievably complicated. We don't understand anything about it. There's no point in even trying to understand it. It's all about dynamic muscle function, and there's really almost no anatomic issue. And what I'm here to tell you is that they are wrong. In a significant number of our patients, there is a clear anatomic issue. Of course, the reality of the situation is that there definitely is a dynamic part to the function of the Eustachian tube. It involves the muscle function, but there is really in many of our patients, especially the chronic otitis media patients, they have a clear, in the majority of cases, obstructive pathology, and a significant number of patients, they have passulous pathology. So if you're going to take one message away from this talk is, in a significant number of our patients, there definitely is an obstructive pathology. It's not all about muscle action. It's not all about dynamic part of the function of the Eustachian tube. And B, and this is something very, very important, in a significant number of our chronic ear cases, there is a passulous Eustachian tube. And when you see a lot of retraction, sometimes you're thinking it's obstruction, but it really is passulous Eustachian tube. And what happens in these situations is that the patient is, because the Eustachian tube is passulous patient, and that really irritates patients, the patients ends up creating a sniff to close up the Eustachian tube, to bring these mucosal flaps together and being held together by the surface tension of the mucosa. So they don't have a passage eustachian tube. And these patients, it's usually very easy to figure out. And when you talk to, first you look in the exam, you see this tremendous amount of retraction. And you ask them, okay, do a Valsalva, and they whether modified or regular Valsalva, and they end up really sort of moving their eardrum. And then immediately, as you continue on talking to them, you'll see that they will go like, they will sniff. And, ask them, why did you do that? And they will tell you that they cannot talk to you if they don't sniff. Because if they don't sniff, the eustachian tube is open, and they really feel very uncomfortable talking to you because the sound goes into their ears. So again, I think this is also a big misconception, is that that there is no anatomy involved, that is all about function. And I admit there is a very complicated aspect to the function of the eustachian tube, but there definitely is a obstructive pathology in the most part, and there's also a passage pathology in the other. So why do I know that? Because this is what I do in every chronic ear case that I see, and I do that in the operating room. And you can see this is like my little contraption that I figured out myself. So what I have here is basically this endotracheal cuff pressure measuring device. And this, you see, basically most sophisticated anesthetists now, they don't go by feel, they measure the pressure of the cuff. So they basically pump the thing here until they end up with a certain pressure that they feel is good for the cuff of the endotracheal tube. And once they reach that point, they basically stop and they disconnect the device. So the way I'm using this is very, very different. This is a number 8 Foley catheter. And of course have two channels. One channel basically for the urine to come out, and one channel for the balloon to be inflated so it could hold on in the bladder. So I use this in the ear, basically. I use the balloon channel from here to close up and seal off the ear canal. And I start pumping pressure inside the other channel into the ear. And the moment the eustachian tube, there's enough pressure in the ear to open up the eustachian tube, you see that the pressure monitor goes back like this. And let me show you what I do. So this is a video. So this is measuring the opening pressure of the eustachian tube. You can see this is a number 8 catheters. I'm just, this is surgery. So I sealed up the ear with a balloon and pumping the air into the ear. And you can see that there's a sealing. So all of a sudden, when it reaches a certain number, it drops. So this is the opening pressure of the eustachian tube. And this, to me, basically tells you two things. It tells you, A, whether you have an obstructive pathology in that specific ear, and second, whether you have a passage pathology, or whether you have a normal eustachian tube function. So usually, a normal eustachian tube opens up around 50 centimeters of water. And in many of our chronic ear cases, you go up to 100 centimeters of water, and you really cannot open up the eustachian tube. Just a word of caution: don't do this after doing a significant dissection in the ear, because if you have an open vein, you could basically inflate air into this and create some air emboli and create some big disaster for the patient. And actually, again, this is going back to my comments about, like, in medicine, once we try something and some terrible thing happens, we end up naturally not trying it again. But really, medicine moves forward, and there has been, like, I don't know, some 80 years ago, there was some reports of emboli, and that's what stopped people from doing this more, testing the opening pressure of the eustachian tube. But I really think now with endoscopic ear surgery, when you do stuff in a very limited way, the risk of that does not exist. So moving on to further misconceptions about the Eustachian tube, and I think this is the biggest misconception, and I have a lot of argument with my friends about this, including Dennis Poe and Holger. I know that everybody is talking about dilating the distal or nasopharyngeal segment of the Eustachian tube. But I think the reality of the situation, at least in the chronic otitis media patient, is that the area that we need to care about is toward the tympanic side of the Eustachian tube. This is really the area that's sort of narrow. The distal Eustachian tube is unbelievably big. And it is very, very hard for me to accept that that part of the Eustachian tube is obstructed. This area is a natural area for obstruction. It's small and it's in close proximity to the tympanic cavity. So it does make sense. We know that patients and societies that don't take care of their ears when they're young, have a lot of infections, don't get tubes, don't get antibiotics. They end up basically with a lot of infections, a lot of scarring. And it is really makes sense that that scarring of the Eustachian tube would occur in the area in proximity to the infection area, which is the tympanic cavity. So the area that we're talking about is not really the end of the Eustachian tube, this isthmus area. It really is the about 1 centimeter away from the opening of the cartilaginous Eustachian tube. Why do I think so? First, there was this study published in the laryngoscope in the year 2000. And this is by Dr. Lindstrom from New York. And what he had done basically at that time is that every ear case that he had done, he would introduce a small fiber optic catheter into the Eustachian tube, and he found out that really the most important area for the obstruction is really on the upper end, closer to the tympanic cavity, rather than towards the distal end of the Eustachian tube. This is a paper that I have published in the laryngoscope, and I looked at my patients who I had done chronic ear surgery on, and I look at them both ways. First, by doing Valsalva technique, and second, doing surgery by visualizing the protympanic segment of the Eustachian tube. So there was 53 cases, and Valsalva CT actually showed that in the chronic ear cases, the distal end of the Eustachian tube was more patent than in the non-chronic ear cases or in the control group. And there was a clear obstruction almost in 2/3 of the protympanum or the ear side of the Eustachian tube in almost 2/3 of the patients. So I really think that we should focus our attention on this end of the Eustachian tube. As you can see it here. And this is a case of mine. And this is a patient, if you're thinking that this is a pre-op picture, actually this is a post-op picture. Actually, this patient was actually an employee in the hospital that I work in, or I used to work in. He had done a tympanoplasty probably like 10 years ago. And he did well, had a healing of the perforation, and then went back home to Morocco, and then came back a few years later, and this was the picture. He reperforated. And at that time, like initially, I did the surgery using the endoscope. But again, like all of us, I was indoctrinated not to look into the protympanum. But this time, second time around, I looked in the protympanum. You could see this clear obstruction of the protympanum. And this is a Valsalva CT. And this is, you can see the area of the obstruction of Valsalva CT. The thing about Valsalva CT is that if one side of the Eustachian tube is, you could visualize, you should be able to visualize the Eustachian tube, the whole length of the Eustachian tube on the other side. So that alone if it's happened on both sides, does not mean anything. But when one side really visualized and the other side doesn't in certain area, it indicates that the pathology exists in that location. So this is a picture, and I did a balloon dilatation, and this is the picture post op. So let me show you this other case. This is a right ear. You could see this patient had retraction posteriorly and a perforation anteriorly that basically, I think, saved her ears. And just move. I'm elevating the retracted area of the eardrum. Let's go to the tympani. You see the retracted area of the eardrum. Just advancing, putting the catheter in, station tube catheter. Inflating it. Handle of the malleus, incus stapedial joint. Removing it and looking at the Eustachian tube after dilatation. So you can see a very, very different picture from before. The nice thing about the endoscopic ear surgery is that with, you could really make sure that anteriorly that your graft does not fall in and really obstruct the Eustachian tube. So when you're looking from that end of the Eustachian tube, the anatomy gets a bit tricky in that, of course, the first comment I want to make is that the tensor tympani muscle leads you into the opening of the Eustachian tube. The roof of the Eustachian tube is always the tensor tympani muscle. But there's a lot of false passages here, and it's really dependent on the amount of pneumatization that you have in the protympanum. We're looking here at the right ear of patient. You can see the carotid artery, and you can see the tensor tympani muscle. And the carotid artery and the tensor tympani muscle always go like this, as I had talked to you before. So if you have a very pneumatized protympanum, you end up with a protympanum shaped in a rectangular kind of a shape. When you have a poorly pneumatized, and you have also, when you have a rectangular shape and well pneumatized protympanum, you have a lot of opportunity for false passages here. So you could basically think that this is the opening, you could think that this is the opening, you could think that the opening is here. But really, if you want to find the opening, you follow the tensor tympani muscle. When you have a triangular shaped protympanum, you don't have pneumatization, you don't have false passages, and you basically end up going into the Eustachian tube. So again, you want to find the Eustachian tube, you follow the tensor tympani muscle, and it leads you to the opening of the Eustachian tube. It's not here, it's not here, it's not anywhere. There's always a lot of recesses here that Daniel Marchioni had called it lots of different names. So I just want to show you this picture. This is a live patient looking at the protympanum. And if you're looking at 30-degree endoscope, and initially you're thinking, well, yeah, this could be this is the right ear, this is the hand of the malleus. You could think, oh, well, this is the Eustachian tube. But if you look further, you recognize that this is a recess here in between the carotid here and the tensor tympani. And the Eustachian tube is a more lateral position. So the way I do the dilatation is that I usually use a balloon that's from the German company Spiegel and Theis. It comes with an introducer. I make a bend in the end, and I loop the other end of that introducer or that guide wire. So basically, you gotta make the corner. So you see, I'm introducing it, and I'm trying by turning that loop, I could direct and I feed it over. take out the slit. And then to make sure that on the Eustachian tube, I could do with this catheter pull in. And the idea here, let me just, sorry. So the idea here is that when you inflate, if you're in the right place and you inflate the Eustachian, the balloon will escape into the nasopharynx, because again, the distal end of the Eustachian tube is, so when you see that, that's a catheter pull in. It means that you're in the right place, as if somebody is holding the other end of the catheter and is pulling it towards him. So that to me indicate that you're in the right place. Because again, given the shape of the Eustachian tube, if you're here and you inflate the balloon, you would basically, the balloon would have a tendency to fall into the nasopharynx. So this is the catheter pull in that I had described. And I think really the reason that they use a lot of introducer when they do it from below is because they don't want you to see that the Eustachian, the balloon is really floating within the distal end of the Eustachian tube, because the distal end of the Eustachian tube is too big, and it basically does not need dilatation. So this was published a few years back, and it was my initial experience. It was published in the ACTA in 2015, my pilot study of transtympanic dilatation. And this was published in Otology, Neurotology more recently. It talked about 40 cases. And the criteria for selection was basically an opening pressure more than 50 centimeter of water. So going back to this, before I would do any dilatation, I would make sure that the opening pressure is more than 50 centimeter of water. And this is after dilatation. So you could see almost in every case, if you dilate that upper end of the Eustachian tube or the ear end of the Eustachian tube, you have a dramatic drop in the opening pressure of the Eustachian tube. And that to me indicates further confirmation of my thesis, is that the ear side of the Eustachian tube is the part that you need to worry about. This is the area that we need to worry about, at least in the chronic otitis media patients, and the patients who have prosthatoma, the patients who have continuously draining ear. But I have to tell you that this doesn't mean that what I'm doing works. Actually, my initial report shows that it doesn't seem to improve outcome in terms of either closure of perforation or reduction of the recurrence of the disease process. But there were definitely no carotid complication. But there was times where we created some damage to the ossicular chain. And I think really a huge area of progress could happen here if we end up combining balloon with navigation, because that really gives us an idea of the location. You know, the problem with the Eustachian tuboplasty as it stands right now is that we really don't know where we are. And I think you have a balloon navigation, I think you could end up doing things a lot more safely. This is a report from Korea. And again, I don't have any interest in that company, but this company produces a balloon, a navigated balloon. So basically they placed a sensor on the tip of the balloon. So you basically end up knowing exactly where you are. And it's really the same concept of the navigation system that we use in the sinuses. So I think this really could be very, very helpful in directing our attention and making sure that we're dilating the area that we care about safely away from the carotid artery. So one of the, again, I repeat the statement a lot, one of the biggest irritant in my life is that whenever I talk about these things, is that people who do a lot of chronic ear surgery say, well, you know, why are you fooling around with this? Like, you know, we figured this long time ago, we fix patients, we do like our canal wall up and it doesn't work, I do our canal wall down, and we have, but I mean, everybody who practices chronic ear surgery recognize that there is a lot to be desired in the outcome of chronic ear surgery. One of the earliest comments that I heard from my teacher is that once a chronic ear, always a chronic ear. And we need to improve. We need to improve function. We need to improve our ability to resolve the condition that has produced the chronic ear. And I think addressing the Eustachian tube is the right way to go. Also, when you think about audiologic outcomes, everybody starts showing off his results and, saying, no, I use this prosthesis or I use the other prostheses. And we all know that if you have a collapsing middle ear cleft because of retraction, no matter what prosthesis you use, we always get a great results initially, and the results always deteriorate with time. It's a well-established fact. So I think, again, I'm a surgeon myself, but I think we surgeons sometimes think in a very unusual way, and we end up really not helping our patient much. And I really think that you really need to think about your Eustachian tube isthmus. You need to ignore the mastoid, and you need, if we keep hitting the same nail with the same hammer, we're not going to end up with a different results. If you have an interest in endoscopic ear surgery and emerging technologies, join us with the International Working Group meeting in Kyoto. I think they're changing it now because of the COVID situation towards the end, toward the fall. But of course, Kyoto is the cultural capital of Japan, and the host, Seiji Kakihata, is really an incredible host, and he's had a tremendous knowledge and experience, and we're all the international working group is going to be there. So please join us in Japan. So I'm done. I hope if you have any questions for me, you could either wave for me so I could open up the microphone, or you could write something on the chat. This is, I keep saying that this is not an invitation for people to run around and do dilatation and stuff, but this is really what I'm trying to show you here is the fact that it's we all of a sudden now we have a good access into those areas, and we have the opportunity of improving or addressing the underlying pathology. So it's a question on the chat line, what are indications for Eustachian tube dilatation besides otitis media? I have to tell you that, to me, this idea that the patient complains of a blockage in the ear, and we move around and say, oh, this is a Eustachian tube, and we do dilatations and stuff like that, I don't really subscribe to that idea. I think, pressure sensation in the ear probably is more indicative of a migraine or primary headache condition, as you have heard during previous sessions. So and TMJ, either TMJ or migraine-like situation. So I don't really go by patients' just subjective thoughts that I have symptoms in the ear, so I'm going to do. I always actually go into this explanation with the patient. Patient a lot of times they end up recommended for tubes by somebody else, and they come and ask me, and I say, well, listen, if these tubes has never worked in my hand, meaning that if you just have a blockage in the ear and you put the tubes inside the ear, I've never seen patients getting better, so I'm very suspicious of that. And but I want to just mention one. If we have a reliable treatment of the Eustachian tube dysfunction, it is the tympanostomy tubes. So I'm not trying to downgrade the tubes. I think that the tubes are the only thing that works nowadays. What I'm trying to say is, don't run too much with patient symptoms and make big decisions on it. You need to have objective findings, either visually or through tympanometry. Is there any other questions if you guys have for me? I'll be having one new message. That's all. Professor Zatoris has that case. What's your recommendation? I really think, and hopefully I will share with you these thoughts some other day. I really think that if you have pathology of the Eustachian tube, it is in that location. It is not like slightly up the Eustachian tube, as most people would like to think. But so to me, Eustachian tube pathology exists in two locations. One, towards the ear side, again, in the area of the isthmus, and the other one is really towards the opening of the Eustachian tube into the nasopharynx, not into the Eustachian tube, but the actual opening itself. So you've mentioned the torus, you mentioned sometimes you get this incredibly floppy mucosa, whether it's allergic in nature or it's infectious or it's reflux, caused by reflux. So I think this area needs attention, or the adenoids. I really believe that, like I do everything with the endoscope. But like if I'm doing an adenoidectomy, and I'll share it with you sometimes in the future. I do it with a microscope. I see I really want to empty that area. I really want to have that torus fall back posteriorly to improve the function of the Eustachian tube. Do I perform in patients who describe, I guess you're talking about difficulty equalization in airplanes and stuff like that. I honestly don't think it works. I have done a lot of dilatation through the nasopharynx, and I have to tell you, I know the data is argues in a different direction, but I just don't think it works. My short answer. I think the problem with the dilatation of the distal Eustachian tube, as been prescribed, is that really is a very, very blind procedure. You make a thousand assumptions. You make an assumption about the pathology existent. You make an assumption that you're in the right place. You make an assumption that you dilated, and you make an assumption that the patient is getting better. I really don't like all of that. I would like to see what I'm doing. I'd like to see the difference that I'm making, and I'm very doubtful. Eustachian tube dilatation done one time. Of course, the question is a very valid question. I do it from the ear side, so I mostly do it one time only when I'm doing my chronic ear surgery. I think there's a lot to be learned in the future. So it's an area of development. And I think that's what interests me in this. I think we need to look further. And I think we'll find more answers. I'm going to say goodbye to you all. Thank you again. Tune in tomorrow again, Richard Harvey from Australia, a very good speaker and a very important topic regarding the frontal sinus. And have a nice evening, and take care of yourself. Bye-bye.